All right, hey everyone, my name is David Kaltman. I'm a resident at Northwestern, and the title of today's talk is ConstipatED, Give a Shit About Shit. I have no disclosures. So we're at an emergency medicine conference here. You may be wondering, why are we even talking about this topic? But I would contend that you should be worried about you-know-poo, because there's a health-related quality of life impairment that's similar to diabetes. So these patients with chronic constipation, their quality of life is severely impaired, and I'm going to empower you with some tools to try and help you make a big difference. There are over 700,000 annual ED visits related to constipation, with a cost of over $1 billion, with the largest demographic groups being the infants and the late elderly. So this is a costly problem, and one that you are going to see very often in your emergency department. There are a number of can't-miss diagnoses that you should be considering, namely GI malignancy, bowel obstruction, and fecal impaction. And we'll talk about how to tailor your history and physical exam to not miss these when the patient presents with constipation. So you should ask about the movement of gas through the system, is there blood present, and take a thorough medication history to make sure there aren't any offending agents there, keeping in mind that normal bowel habits could be anywhere from 3 times a day to as little as 3 times a week. In the pediatric patient, beyond those HPI factors, you should think about a number of underlying medical conditions that might be the key to why this patient is constipated, such as urinary incontinence or an overall failure to thrive. Now, when you get to the physical exam, I know that many of us may find doing a digital rectal exam uncomfortable, but this could be really important to identify a fissure or a fecal impaction, keeping in mind that this, of course, may not be indicated in the pediatric patient. Now, when you're trying to work up the patient, many of us think about, well, should I get an abdominal x-ray? And the short answer is it's useful when you're looking for a surgical abdominal problem, but otherwise is actually not recommended by any of the major radiology guidelines. Even in the pediatric patient, unless you're worried about one of these catastrophes in the first few months of life, there's actually very little utility in ordering a plain abdominal x-ray in the routine evaluation of a patient who presents with chronic constipation. And this is because in effort to diagnose constipation, the plain abdominal film has very poor sensitivity and specificity and is therefore not recommended by the major pediatric GI guidelines. A wise attending once told me, if you order an abdominal x-ray looking for shit, you're going to find shit. So maybe we should think twice about whether or not we really need this study for our patients. So now the patient is in your ED and they're constipated, and you want to help them shit. And this very simple algorithm as to how you want to intervene, just 3 words: mush, then push. And the sequence of this is very important: mush, then push, which brings me to this kind of would you rather scenario. Would you rather have a soft stool that exits nice and slow, or would you rather have a hard stool that exits very quickly? I don't think we need to pull the audience here to understand that I think you'd rather have a soft stool that exits very slowly. And so that's the first part of our algorithm here, is mush. You want to prescribe osmotically active agents that draw more water into the stool in order to soften up the stool and make its transit through your intestines a little bit more calm. Once you've sufficiently softened up the stool, or you can prescribe agents like fiber, the most common one being polyethylene glycol. And if you're really interested, you could just tell your patient to eat some sugar-free gummy bears. If you don't know what I'm talking about, you should look this up later today. But once you've softened up the stool sufficiently, you're going to want to try and help push things along. And this relies on the fact that the enteric nervous system controls a lot of things with the GI tract, most notably for our topic today, motility. And so there are a number of things that you can do to try to help move things along in someone's intestines. The 2 most common agents that we think about in this scenario are senna and bisacodyl, which are both cheap, very widely available, and are available in both oral and suppository forms. So they should be easy to prescribe for your patients. Now, once you've gotten through the mush, then push, if you've already gotten through that part of the algorithm, the next steps may be manual disimpaction or, frankly, just more polyethylene glycol. This is what's used in bowel preps and is very safe even in quite large doses, having very minimal systemic absorption. Beyond our scope today are some other kind of more expensive agents that are mostly within the purview of the gastroenterologist. Some more advanced things like biofeedback, or at the end of the line, procedural interventions such as colonoscopic decompression. So just to recap from today, you should ask the patient your history about things moving in and out. Is there blood? And take a good medication history. The abdominal x-ray is really only useful if you're looking for surgical abdominal emergencies. And if you remember nothing else from today, just remember to mush, then push. Thanks all very much for your time. I'd like to thank all my colleagues from Northwestern who are here today, and hopefully this wasn't a shitty talk.
I want to thank you for ending the session on a humorous note and bringing up a topic that we do need to address in the emergency department. And lastly, thank you for reminding me to look very closely the next time I buy gummy bears and make sure I do not get the sugar-free variety. So thank you.
Thanks.